Kirakoto. My name is Jesse. I'm an anesthetic technician. I'm working in New Zealand. So to continue with the crisis management, the topic today I will mention about laryngospasm that we normally come up with the patient during inductions or extubation. So all the material I use in this video belong to one of the hospital that I work in New Zealand. So one day, never know, you come to New Zealand and work and you get familiar with the protocol and how we can deal with the crisis management. So I hope you can subscribe to my channel and share my channel to the people that are interested to work in New Zealand. And hopefully I will see you one day in New Zealand. Okay. Right, with the patient, if we come up with the patient, we have the laryngospasm. First thing we have to do that the main priority break laryngospasm and maintain SpO2. So the first thing we ask the surgeon to stop, delegate or prepare for intubations. So we have to use the susamethonium and then endotracheal tube. In other country we use succinylcholine, we call now in New Zealand we call it susamethonium, and manual procedures remove LMIs and clear the airways. Consider OP or NP airway, like OP like oral pharyngeal airways or nasal pharyngeal airway, and jaw thrust and CPAP 30 centimeter of water, and do not give positive pressure breath. Applies bilateral painful inward pressure to the larsen point just behind your earlobe. And if pediatric, consider gentle chest compression. That's for pediatric. And if SpO2 stable above 92%, try pharmacological relaxations. Like you can give propofol like 20% of the induction dose. Like induction dose we use like 2 milligram per kg. Or susamethonium 35 milligram, and pediatric like IV like 0.5 milligram per kg. And if the SpO2 drop below 92%, proceed to intubation without delay. Adults we give susamethonium like 100 milligram, and the pediatric we could give susamethonium IV for 2 milligram per kg on IM intramuscular injection like 4 milligram per kg. Consider atropine 600 microgram for pediatric like 20 microgram per kg for bradycardia. And consider stomach decompressions after the event. So that's the first thing we have to do if we come up the patient had the laryngospasms. The first thing we have to ask what we have to do, and then we follow the guideline. And then we have to do the investigation why the patient get the laryngospasm. Right. Furthermore, laryngospasm will break with sufficient time, and hypoxia may be preceded by bradycardia, cardiac arrest, and aspirations, pulmonary edema. Hypoxia may occur rapidly in pediatric, obese, and acutely unwell patients. Prepare IVs and IM dose for such and in such cases. For these cases, we have to know that like patient with like pediatric or obese, like acute unwell patient, they have more likely get the desaturation quickly. And laryngospasm, they can cause like proceed like bradycardia and cardiac arrest, like aspiration, pulmonary edema, and then we have to prepare for sucks in this case immediately. Right, to treat with this laryngospasm for drug and equipment dosing. For pediatrics uncuff, we have endotracheal tube preterm like 2.5, and then below 1 year we use 3.5 to 4 size, and then above 1 year old we use like 8 divided 4 blood 4 for uncuff, and then blood 3.5 for cuff, and propofol 20% of the induction dose. Succinylcholine relaxations 0.5 milligram per kg, and intubation for adult we use induction dose or 100 milligram, and pediatric we use 2 milligram IVs and IM 4 milligram for pediatric. So laryngospasms is a very common thing that we normally come up during our daily work. And in New Zealand, mostly if we patient come up with the laryngospasm, we like I said, we have to make sure that we give the FiO2 oxygen 100%, and we give them the CPAP, like continuous positive airway pressures, and we try to break the laryngospasm. And it depends on semi laryngospasm or totally laryngospasm, and then we give them oxygen, make sure that there are no stimulation for the patient, because there are a lot of factors that can trigger the laryngospasms. Like we can have like surgical factor or patient factor or anesthesia factor. So in this case, normally I see the anesthetist will give, if the patient is sleeping, we give patient deeper anesthesia to relax the and break the laryngospasm, or give the like I said in the video, like the guideline, we give the propofol, like 20% of the induction dose, and then succinylmethonium to help the patient to get back to normal. That's what we do in New Zealand. And if some certain case, like the rule of thumb, that make sure that you have to be safe and patient safe in this situation. Like you cannot like leave the patient long. So if you have a need extra help, you have to press the emergency belt, so call, so a lot of staff will come and assist you what we need for in this case. And that's it. That's what I normally do. Like if the patient get laryngospasm, you make sure that we get because the anesthetist will control the airway straight away, and they can put the IPL valve up, and then for this case you have to draw up quickly the propofol, or you the muscle relaxant, and then anesthetist will instruct you, like you can give how much to the patient. All right, thank you very much, and I hope you can share and subscribe my channel, and we can build up a strong channel for anesthetic technicians. And because I'll build up this channel because I want to introduce how wonderful the anesthetic technician in New Zealand, and how it's beautiful country. And a lot of people, they asking me like, how can I become an anesthetic technician in New Zealand, although I got trained from another country. And yes, like the previous I mentioned, like how to become an anesthetic technician in New Zealand, you just go through the Medical Science Council, read through all the information, and then you have to apply for the registration. And then nowadays you have to do the online exam. Yeah. Previous the online exam, I have to do the exam, practical exam on site. Okay. All right. Thank you very much, and see you in the next video.